I'm here with Laurien Buffart from the Netherlands, our international speaker at ANZUP 2023. Laurien, thanks for coming to Australia. It's a pleasure to have you here. Look, a very nice presentation, very impressive data pooling that you've done with the Polaris Consortium that took really 10 years, and it's getting a lot of publications and important new evidence for the role of exercise in managing patients with cancer. Can you maybe highlight to us some of the key papers and findings from this extensive work that you've done?
Yeah. Well, first, thanks for having me here. It's been great to come here. I think one of the key findings, of course, is that we now were able to provide solid evidence that exercise is effective on a range of outcomes, including physical fitness, fatigue, quality of life, cognition, and sleep. The huge data set really allowed us to identify differences between patient subgroups.
Laurien, it's an impressive data set with 4,000 participants. From an exercise oncology perspective in terms of trials, this is very significant, because often it's difficult to recruit for exercise studies because it's a behavioral intervention. Often the trainer, the exercise physiologist, will see the participant 2-3 times a week. So it's hard to run exercise studies. So when you're pulling 4,000 participants from different eras and continents, that's interesting. So how do you see that? I mean, in terms of how do you use those findings in terms of different areas?
Yeah. Well, I think it's because it's such a large data set that which you wouldn't have in single trials. It really allowed us to study differences between different subgroups of patients. And also, of course, between different countries. But I think the differences is more between the subgroup of patients rather than between countries.
Okay.
So, looking into different.
Yeah, and Laurien, with this, one of these papers are specifically looking at patients that were during therapy versus non-therapy. Can you maybe mention some of the outcomes for that particular analysis?
Yeah. So we studied whether the effects of exercise differed between people who are still on active treatment, for example, on chemotherapy or on hormone therapy for prostate cancer, compared to people who already completed treatment. And I think the main difference is, of course, that during treatment, the aim is mostly to maintain physical fitness, for example, or to maintain quality of life rather than to improve it. But whilst after chemotherapy treatment, you will aim to improve physical fitness. But the differences between the control group not getting any exercise is still more or less the same.
Okay. And for patients that were not on therapy, these were completed therapy, they still had a response, right?
Yes,
yeah.
They did. Yeah. What we did find is that there were some differences, depending on the outcome. There were some differences between interventions provided during treatment versus following treatment. So, but that was more related to the extent of the problem at baseline, so before starting the treatment. So, for example, if you would have higher levels of fatigue at baseline, you would have larger effects of the intervention on fatigue. And most likely, following treatment, people really are more fatigued compared to some people who haven't started treatment yet. So that could it's more the symptom that's present already rather than the timing of giving the intervention.
Okay. Look, fatigue is an interesting outcome, as you mentioned. It's well reported in the cancer literature. This is across different types of cancers. Is there a specific exercise modality that would be more beneficial for fatigue or not necessarily?
Well, we've looked into that, seeing whether resistance exercise or aerobic exercise would be better. But in fact, we didn't find any differences across different types of exercise. So I think the most important thing is to actually exercise because that's beneficial for fatigue.
Yeah. Look, and that will differ if someone is aiming to improve muscle mass, having issues with sarcopenia, they are on hormone therapy for prostate cancer. So there will be differences in actual prescriptions depending on the aim of the actual program and the clinical needs of the patient, right?
Yes, indeed. So it really depends on the outcome, what would be the best intervention to give. And a simple example, which is of course if you want to improve muscle strength, include the resistant exercise, because otherwise it's not just walking alone wouldn't be enough to improve physical muscle strength. But for other outcomes, it doesn't really matter. So I think it's very good to know which intervention should we give for which particular outcome.
And look, and this is a clinical need of the participants. What about the preference of the participant and the patient? Is this something that, as researchers, clinicians, is this something that needs to be taken into consideration as well?
Yeah, I think so. I mean, particularly, especially for outcome measures like fatigue or quality of life, when doing exercises is even more important than the type of exercise. So then, of course, it's good to take into account what a patient likes to do, because that's more easy. It's more sustainable. They can maintain that easier on the long term. I think if really muscle mass and muscle strength is the problem, it would be nice to get them, maybe first get them into enthusiastic, but then also try to get the resistance exercises in it to actually have the benefit. But keeping in mind that doing any exercise is better than nothing, should be a priority, and then see if we could fine tune and to get the most out of it.
Sounds good. Laurien, there's also, you did cover aspects of supervision and non-supervision. Can you comment on this? Because I believe your meta-analysis with individual patient data was the biggest one ever published in the topic. So what were the main findings there?
Yeah, we did find that interventions that were supervised by an exercise physiologist or by a physiotherapist, depending a little bit on the country, how the supervision takes place, we found larger effects on those outcomes. And I think this is really important. It's partly, we couldn't look into whether it was, it could be explained by whether the attendance was actually higher when it was supervised or other motivational aspects, but I think the supervision was very important. And maybe you can imagine that if you have to deal with side effects, which are changing over time throughout the courses continuously, that it's actually nice to have an expert guiding you how to deal with that, rather than doing it all by yourself.
Absolutely. I mean, our data also supports the same principle, and even in clinical practice, I think patients really appreciate that initial, at least that supervision in initial stages. Yeah. Look, I just want to change very quickly for us to conclude. Well evidenced, well established effects of exercise in terms of function, quality of life, many different types of cancers. This is 20 years of data now, including your substantial work. Moving forward, you briefly mentioned about potential biological mechanisms. Exercise might actually improve the sensitivity of therapy. There's a number of preclinical works being done in this area, even the efficacy of radiation, you gave an example. Do you want to comment, what do you think might go in the next 5 years? A lot of the focus is now potentially the role of exercise in playing an important role, not just in reducing toxicities, but also might improve the efficacy and have clinical outcomes or cancer-related outcomes.
Yep. I think it's a very relevant question to address. I mean, there's substantial research that's showing that quality of life and physical fitness and function improves. But I think to get it reimbursed and really actually as a part of clinical treatment, it's good to know whether exercise is actually beneficial for clinical endpoints. And preclinical studies do show evidence that exercise could actually help to reduce tumor growth. So I think the big question is, of course, how does it translate to patients? The amount of exercise that mice can do, couldn't it be the same as a patient who also has to deal with comorbidities or other problems? So is the exercise that the patient could do, would that be also sufficient to indeed improve chemotherapy or other treatment efficacy?
And thanks, Laurien. What I think is also encouraging is all the epidemiological data, and you as an epidemiologist, we're looking at about 30 to 40 studies now showing this association between higher levels of activity and reduced recurrence, improving cancer-specific outcomes. How do we interpret that data? Because now we have the preclinical data, the epidemiological data. I mean, this is all kind of going in a one interesting direction, in positive direction, right?
Yeah, I think both the observational studies and the preclinical studies do show that there may be a link between exercise and treatment outcome. I think the big question is, can we also find that evidence in trials? And I think that is an important step that we need to take as researchers to find that, to see if that's really true. from observational studies, we indeed see that people who are more active have a lower risk of recurrence, for example. But you never completely know whether those active people are actually more active because they have the less disease burden, or it's because their level of physical activity. And I think solid trials will be able to distinguish that. So it's an interesting angle I think we need to look into. Yeah.
Absolutely. Laurien, thank you very much for coming to Australia and to contribute to ANZUP 2023. It was a pleasure having you around, and we'll see you next time.
Well, thank you very much for this nice conversation.